Next speaker is Dr. Padmanabha Shenoy. I invite Dr. Padmanabha Shenoy. He'll be speaking about measuring ankylosing spondylitis and basically outcome measures in seronegative spondyloarthritis. Dr. Shenoy is the HOD of Department of Rheumatology at Amrita Institute of Medical Sciences, Kochi. He's done his MD from JIPMER and DM from SGPJ Lucknow, and he has various publications in national, international medical journals and various awards also, including gold medals during MBBS, MD, and then he was the best resident in he got the best resident award during his DM days. So I request Dr. Shenoy to kindly deliver his lecture.
Good afternoon. At the outset, I would like to thank Dr. Chandrasekhar and the Chapter team for inviting me to speak to this august audience. And my person Yogesh is the chair. Yogesh is a long-term friend and he's my batchmate. Thanks for those kind words. So, just straight away moving to the outcome measures in spondyloarthropathy. Today, Dr. Chandrasekhar said, we are aiming at treat to target. When we are aiming at treat to target, we need to have a target. If we need to have a target, we need to have outcome measures. What is spondyloarthropathy is basically, spondyloarthropathy is a group of diseases where the major disease or classical disease is angst, and there are certain diseases like underfusing USPA, psoriatic arthritis, reactive arthritis. All these diseases are overlapping with spondyloarthropathy, or they are grouped under spondyloarthropathy. I will be majorly speaking on angst and a bit on psoriatic arthritis. So when we think of assessing a disease, what we are aiming at is having a normal quality of life. So the quality of life depends on two things: one, activity of daily living, and body structure. This in turn depends on two things: one, it depends on activity, and second, damage. Activity is basically the symptoms and the inflammation which we try to quantify, and equally important is damage. Both structural damage, especially at the tissue level, in spondyloarthropathy at the level of the bone. We think that activity is reversible and damage is irreversible. So it's very extremely important to differentiate what can be done to the patient and what is damage. And there are a whole lot of factors, including personal factors. There is age, there is gender, there are coping mechanisms, there is psychological issues, support system, socio-economic factors, whole lot of things which determine the functioning, the way the patient functions, and what is the quality of life of the patient. So I will be majorly dealing with, I am not dealing with all this because this will be very complex. I will be dealing with these two things: one, activity, and second, damage, how to assess this, especially in spondyloarthropathy setting. So this will be my format of talk. First, coming to ankylosing spondylitis and how to assess the activity of ankylosing spondylitis. As we know, ankylosing spondylitis is a disease which affects the spine. So the first question will be, the most important question is spinal pain. And there are two types of scales which have been used. One is visual analog scale, which is a straight line and the patient will mark how much pain does he feel. And another one is numerical rating scale, or NRS, where patient can circle one of the scores. The very important thing what we should understand is that pain can be either a marker of inflammation or can be a marker of damage. So it is not absolute that pain is equal to inflammation. Pain can be because of damage, especially in spondyloarthropathy setting. And second very important thing is morning stiffness. Both duration of morning stiffness and severity of morning stiffness are important in the case of ankylosing spondylitis, and usually what is used is numerical rating scale. If someone has a early morning stiffness of 1 hour, we give a score of 5, and if it's more than 2 hours, you give a score of 10. And the question is, how long do your morning stiffness last from the time you wake up? These questions are framed in such a way that you get an optimal response. And fatigue, as we know, fatigue is a very important part of these diseases. The amount of fatigue, 60% of the patients are fatigued. It has a huge impact on quality of life, and it has more impact, or at least as much impact as the pain has on the quality of life. Usually it's assessed by visual analog scale. Visual analog scale is the easiest one. There are multiple scales available, but usually visual analog scale is used, and which is sufficient. And in that question you ask, how much fatigued are you in the past 1 or 2 weeks? So based on this, where people have done a composite score which assesses the activity as a whole, which is called BASDAI. BASDAI is Bath Ankylosing Spondylitis Disease Activity Index, and in the BASDAI there are 6 questions. The first one is fatigue, second is spinal pain, third is peripheral arthritis, fourth is enthesitis, fifth is fifth and sixth are morning stiffness. I told you both the intensity is important and duration is important. Based on that, there is a score which is calculated. There is a very simple formula which can be done very easily in OPD. There are Excel sheets available, so you just enter the data, or otherwise also you can hand calculate this, and you will get a score. That score is called BASDAI, or and the score indicates the activity of the patient. But there are certain problems. First, what is the minimally clinically important MCID? For those who do not understand this, this is how much score is clinically important. For example, if someone has a score of 9, if he improves to 8.7, that is not clinically important. What is important is 9 to 8 or 8 to 7. Improvement of 1 score is important. And what is bus cutoff of symptom relief? People have taken less than 4. If BASDAI is less than 4, it is acceptable. Like Madam told, ASAS of less than 1.3, something like that is BASDAI less than 4. But the problem with this is, it has a huge weightage on peripheral arthritis. If someone does not have peripheral arthritis, scores will be very low. So the false values are there once you do not have peripheral arthritis. And even if someone has only the severe ankylosing spondylitis, severe back pain and morning stiffness, you do not get a score of 4, 4.5 because you do not have peripheral arthritis. So people have devised something called mini BASDAI, of which peripheral arthritis and enthesitis are excluded. So we can very clearly see this, 3 and 4 are excluded, and that is much better when you do not have peripheral arthritis, and it correlates with and is very useful in those patients who do not have peripheral symptoms and have only spinal symptoms. So this is one of the common questions what we ask. How are you feeling today? This is a wonderful question, nothing as good as this question, and it is very simple, single, but the problem is it is highly variable. The people have done research on this. What they have asked is, how active was your spondylitis on average during this week? And patients put a score. And see this correlation. This was long back published in 1990s in Oxford Journal. See the correlation, 0.7. But the thing is that what we should clearly understand is that this as a single alone measure is no longer used, but as a rough measure, if you do not want to use BASDAI, other things, although it is not recommended, maybe you can try at least this. At least this you can try, but for every practical purpose, you have to use BASDAI as the outcome measure in a patient with ankylosing spondylitis to assess the response to treatment. And so coming to the second thing, which is spinal mobility. As we know, spondyloarthropathy affects mainly the spinal cord. At every level it affects, starting from the cervical, thoracic and lumbosacral spine. In the cervical spine, you assess the mobility by occiput to wall distance, tragus to wall and cervical rotation. And thoracic, you do it by chest expansion. Lumbosacral, you do by lumbar lateral spinal flexion and modified Schobers. And hip, you do by intermalleolar distance. It is very important that all of us standardize these techniques, how you do it. Tragus to wall distance, there are standard methodologies. What they do is, patient has to stand against a wall, and you look at the chin, very very important, the position of chin is very important. It has to be horizontal, and pull the maximal effort to move the occiput against the wall and measure the distance. You can see this is occiput to wall and this is tragus to wall. Tragus to wall is more reliable, and you measure the tragus to wall, and if the tragus to wall is less than 15 centimeters, you give a score of 0, 15 to 30, moderate. And if the patient is bending this side, that is, if the patient is bending forward, which happens in ankylosing spondylitis, tragus to wall distance will keep on increasing, and you give a higher score. Coming to cervical rotation assesses the mobility of the cervical spine. Is used by a goniometer. Goniometer is first put straight, and then the patient is asked to rotate the head the maximum to the left and right, and you can see this angle is being measured by a goniometer, and if the angle is more than 70, it is normal, 20 to 70 is mild restriction, and less than 20 is severe restriction. Chest expansion, hands is basically done, all of you know I suppose, hands, this is the position what you have to do at the level of 4th intercostal space anteriorly, and maximal inspiration and maximal expiration you measure, and the bust of the two tries you take. And BASME, chest expansion, is not one of the parameters, that is why I have not put the scores. Modified Schober's, there are different ways you measure Schober's. I do not want to confuse the audience. You can, this is one of the recent recommendation by ASAS. What you have to mark is basically you have to mark a line connecting the posterior superior iliac spines close to the dimple of Venus, and then mark a 10 centimeter above. Ask the patient to bend without forward maximally and measure the difference. And 2 tries you have to give, and if it is more than 4 is normal, 2 to 4 is moderate, and less than 2 is severe. There are different ways, but this is what is recommended by ASAS. BASDAI has slightly different system, but about Schober's, whatever system you do, that is fine, but you have to do the same system on follow up. That is the most important thing. Lumbar lateral flexion, you can see this. You have to the patient has to stand like this, no flexion of the knees, no bending forward. Place a mark on the thigh here, and then you ask the patient to bend nicely and see the difference, how much he can bend between the 2 points. And this is lateral lumbar flexion. If it is more than 10, it is normal, less than 5 is severe, 5 to 10 is moderate. Intermalleolar distance, I told you to assess the mobility of hip. Patient lying down, legs separated as far as possible, and measure the distance between malleolars. People sometimes measure with standing, but always supine is better than standing. That is recommended because of the convenience to the patient. More than 100 normal, less than 70 is severe, so 70 to 100 is moderate. So once we have measured the entire measurements of the entire spine and the hips, then you calculate something called BASME. BASME, basically there are, you give a score based on 0, 1, 2. That's why I have been showing the scores at each level, and then you get a composite score. And based on this composite score, you understand how the spinal mobility has progressed over months or years. 2 issues with BASME. As I told you, these metrological indexes mobility can be restricted either due to activity or damage, and as I said, tissue damage is usually irreversible. So decrease can be due to, and response is slow, very, very slow, and it takes at least 3 to 6 months for the to show improvement in BASME in most of the patients. So coming to the other aspects, peripheral arthritis and enthesitis. Peripheral arthritis, Dr. Vishnu has covered extensively. You in ankylosing spondylitis, you measure the 44 joint count, and the DAS score has been used, although it is not the best. Coming to enthesitis, enthesitis as for the are the sites where the ligaments or tendons attach to the bone. This was the earliest enthesitis index, 1987. You can see the reference, 66 sites, each site 0 to 3. You can see lot of enthesitis. But this is highly impractical, so people can move on to Maastricht mSASSS. mSASSS assesses costochondral junction, anterior superior iliac spine, posterior iliac spine, and spinous process, and Achilles tendon right left. Only 13 sites, very easy, plus or minus, and then get your score. Now people have even moved forward. People have moved to this called SPARCC enthesitis index, very, very easy, only 16 sites. The advantage is that they are easy to locate. See this, lateral epicondyle, medial epicondyle, then you have a quadriceps tendon insertion patella, patellar tendon, plantar insertion, and Achilles tendon. All these are very, very easily accessible. You need not expose the patient, and very easily you can measure this. So this is SPARCC index, and it's useful especially in a setting where you are doing a clinical research and documenting the things. Acute phase reactants. One thing very, very clearly you should understand is that acute phase reactants in the case of spondyloarthropathy can be normal. You see this, 40% of spondyloarthropathy patients have a normal level of ESR and CRP. When the patient has peripheral arthritis or IBD associated arthritis, they go up very high, but there is no evidence of superiority of ESR over CRP, and ESR and CRP cannot be substituted to BASDAI or other measures of activity of this disease. So people came up 3-4 years back with ASDAS. As in rheumatoid arthritis, we are fond of numbers 5, 4.5, 3, 3.5, something like that. So people thought they should introduce something called ASDAS, and this is there was effort which was published in Annals of Rheumatic Disease in 2009. They selected certain variables which are very important, and based on these variables, they developed 2 scoring systems. I am not going into details how to calculate that. Basically, it has some features of BASDAI, patient global assessment, and ESR or CRP. Basically what they have done is they have taken most of the factors from BASDAI and included inflammatory markers, and then they say that it very well reflects the disease activity, and this is the formula by calculating it. It is still being validated. Now also BASDAI is being used in more clinical trials, but ASAS is coming in a big way. So maybe in 5 years down the line, ASAS will be the buzzword rather than BASDAI and other things. Coming to the function, that's what we are aiming at. Function is basically assessed based on questionnaires are there. One question is BASF and other is the Dugdale's functional index. These are scoring systems. There are questions are available. Can you do this or that, or can you bend? Can you put on the shoes? Something questions are there. 10 questions are there in BASF and 20 questions in DFI. And based on that, both are equally difficult or equally easy to complete and very sensitive to change. But BASF is the more commonly used because there are only 10 questions. So I told you what are the outcome measures. So how to assess the response to treatment, that is very important. What people have devised is ASAS improvement criteria. This is the most widely used. In ASAS improvement criteria, there are 4 things which they have taken: patient global assessment, pain visual analog scale, BASF and inflammation. Inflammation is basically nothing but BASDAI 5 and 6. BASDAI 5 is early morning stiffness and duration and how severe it is. So this is BASDAI 5 and 6. Along with they have taken functional index, visual analog scale and patient global assessment. And what they have done is they have devised 2 things, ASAS 20 and ASAS 40. If you have 20% improvement in most of the things, you are the patient has ASAS 20 response. If they have 40% improvement, they have ASAS 40 response. And remission means value less than 2 in all 4 domains. If the value visual analog scale values are less than 2 in all 4 domains, you can say that patient is in ASAS remission. Now because of the availability of anti-TNF, people have moved forward. There are better indices. That's why people have devised something called ASAS 5 out of 6, which indicates that more than 20% improvement in almost all these things. What has been included is BASMI and C-reactive protein. BASMI is metrological index and CRP is a marker of inflammation. They have included that also. If the patient has more than 20% improvement in 5 out of 6, the patient has ASAS 5 out of 6. So coming to structural damage. Structural damage, we think that it's a damage at the level of tissue. It cannot be reversed. Usually this is done by X-rays. That was conventionally being done. What has been done is lateral view of lumbar and cervical spine at regular interval was taken, and also the pelvic X-ray. And there are different systems available. The most commonly followed one is Stokes score or mSASSS or Stokes score. We can Stokes score very easy to score actually. 0 is normal, 1 is erosion, sclerosis and squaring are given a score of 1. Syndesmophyte, which is non-bridging, is given a score of 2, and if total bony bridge is giving scoring of 3. Unlike a sharp score, this appears to be much easier to score. I can tell you, see this score. If there is erosion, score of 1, incomplete bridging, score of 2, and complete bridging gives a score of 3. Let us try this out. See this. This is a erosion. I am not sure whether you can make out this is an erosion. So there I have given a score of 1. There's a mild sclerosis there, so they have given a score of again a 1. You see here, there's an incomplete bridging, or there's a syndesmophyte being formed, so the score of 2, and complete bridging score of 3. It's much easier than the sharp score and the rheumatoid arthritis scores to score and calculate it. Only thing is that you have to have a longitudinal data to see whether the patient is progressing. MRI is coming up in a big way. The advantage is that MRI can image the active axial inflammation. So it does not image the damage. It can definitely image the damage, but it also images the activity. And after giving anti-TNF, you can very clearly see the Romanus lesion disappearing, the Enthesitis lesion disappearing, etc., etc. And it can image the thoracic spine as well. And there are 2 scores, AS spinal MRI scoring system, one for activity and another for chronicity, but it requires a lot of effort and a lot of standardization. So I have told you about so many outcome measures. So what to assess in which setting? The bare minimum is, or physical therapy or symptom modifying anti-rheumatic disease therapy, or like what we are doing most of the time in our clinic, at least is bare minimum is BASDAI and BASMI on a regular basis. You have to do BASDAI and BASMI to see whether the patient is responding. You have started the patient on NSAIDs, how the patient has responded. You have to start with the patient on sulfasalazine. BASDAI and BASMI are bare minimum, And for clinical record keeping, then you have to look at acute phase reactants and peripheral joint disease and Enthesitis, especially for what you are planning to keep a database to see at a outcome measure at the 5 years, 6 years, something like that. If you are having disease modifying anti-rheumatic therapy, like in the form of anti-TNF, people are claiming that anti-TNF and NSAIDs are disease modifying drugs, especially anti-TNF. There is data coming up that they are disease modifying and it can prevent the structural damage. Then you have to have a spinal radiograph along with all this. So, coming to psoriasis. Psoriasis, we know there are different domains. It has peripheral arthritis. Peripheral arthritis is basically done by, there are tender joint count and swollen joint count. Then there is enthesitis and axial disease, which is done by spondyloarthropathy, same almost similar scoring system like BASDAI and SPARCC and mSASSS. Dactylitis is very easily scored, plus or minus. And one thing is different is, unique is skin and nail disease, which is done by PASI and NAPSI. Psoriasis, this is PASI. PASI score is basically a bit complex. It is not very easy for a on a routine clinical setting. Basically, you have to rate the erythema, you have to look at the surface area, then you have to multiply it and you get a score. That's what PASI score is. The only point is that what I am to put across is, once the patient, you start the patient on anti-TNF and some really effective medicines, it is very useful that you calculate the PASI score over time and you measure it. And there is a responder criteria which is psoriatic arthritis responder criteria, at least improvement at least 2 of which must be 2 of 4, 1 of which must be tender joint count and swollen joint count. I am not going to details of which. What I am trying to tell you is, psoriatic arthritis also has a different set of criteria rather than the rheumatoid arthritis or ankylosing spondylitis. And once you follow up psoriatic arthritis patients, it may be useful, worthwhile exploring this. So, take home message, outcome measures has to be based on what clinical setting and what based on your practice. But some form of outcome measure is extremely important. Treatment based on gut feelings can be horribly go wrong, because we have to assess the response and we have to assess the change of, we have to see whether the treatment has to be changed if the outcome measures are not improving, or we have to see why the outcome measure is not improving. And radiological assessment is tedious, I agree, but it's definitely useful, at least in the research setting. If I can summarize my whole talk in one sentence, it is extremely important for all of us who manage spondyloarthropathy to use at least BASDAI and BASME on a regular basis in our clinics. Thank you.
Thanks, Dr. Shenoy, for your talk. The topic is open for discussion and questions, please.
What is your personal opinion about using this BASDAI, the patient global? How easy is it for you to elicit in your
Extremely difficult. At least what I do is, one of my physiotherapists or one of the assistants do it. It is extremely difficult because it takes a lot of time. I think the best thing is, first time it's extremely difficult, but the second time it becomes much easier and they ask for it. First time is extremely difficult to tell the concept of converting the pain to a score. I don't know, Indians maybe they understand the money better. So I asked them, how much paise do you feel out of 100? I'm sure this is tricks we have learned together, we and Vishnu have learned long back. We used to ask this, how much paise do you feel out of 100, and convert it to a score. And second time maybe, third time they come out. First time, but it's extremely difficult. I agree. BASME, but can be done.
You can train your physios or somebody to do that.
Yeah. But BASDAI, I agree. Visual analog scales are difficult to understand.
If the patients can afford, an MRI scan replace this, can't they?
Sorry?
If a patient can afford doing an MRI scan on an annual basis.
See, okay, so I have been trying to validate these MRI scoring systems, but I have been unsuccessful, or I have not been successful. Frankly speaking, I have not been, because their scoring system is a bit complex. And what are you trying to achieve? That is the one thing. We know that anti-TNFs remove the enthesitis, and definitely we can, annual basis MRI is not recommended unless you are doing somebody on a 20 patients on research, you are giving anti-TNF on a regular basis, and other group you are giving anti-TNF on a intermittent basis, and see how these 2 patients are responding, then annual MRI may be worthwhile. But I don't think it is going to be the standard of care, at least for the 2-3 years to come. Yeah, activities. But it can pick up these Romanus lesions and other enthesitis.
I have to say the AS, the assessment process is so tedious and time consuming. And you definitely need a separate clinic, which is what we used to do abroad. Like there was a physiotherapist running a separate clinic just to do the BASMA and the BASDAI. And
That's what we were telling. It's not impossible for a clinician to spend 20-25 minutes of your practice for just a thing, but your physio can very well do it, or clinical for that nurse, rheumatology nurse, anybody who is trained for 3-4 months can do it.
So
One more question, please.
This BASDAI questionnaire used or a tool used to diagnose the patient or measure the patient disease. Are you able to audible? Audible, sir?
No, yeah, tell me.
Sir, BASDAI used as a tool to measure the disease. Okay, sir. But you have a BASDAI questionnaire. If you look into that, there are set of questions, set of items, right? So each items you are given an equal weightage. How do you feel that? How do you say that?
That's what I am trying to tell you. In BASDAI there is overweightage of peripheral arthritis. Because as we understand, ankylosing spondylitis, most of them will have systemic spinal symptoms rather than peripheral arthritis. So that's why people have come out with a mini BASDAI, and these are also not perfect. That's why people have come out with a newer thing called ASAS. BASDAI is not the perfect one. People are trying to improve upon it. BASDAI